started green. Okay. Well, I think welcome to. Can we just go back one first? I just want to look at the agenda for everyone. Yeah. So, well, welcome to the laser symposium, and my name is Victor Chong. I'm going to tell you a little bit about something that you already know very well, but I just want to go through it in the way that how things that laser have we can't know more when you got a little bit more clinical data. And we're also going to talk about CSR. We're also going to talk about a different type of laser, and as well that be slightly more interesting about laser to drusen. And unfortunately, Dr. Wu not able to join us. He's in Costa Rica, but we had a recorded call for that. So let me just start on my talk. And so this is my financial disclosure. I'm a consultant for Quantum Medical. So I went to a meeting in Miami a few years ago, and then they basically say that the requirement is to get the take-home message out first. And I thought about it. I thought that's a quite good idea, So at least that this is the take-home message. So if you want to leave the room after the take-home message, then goodbye, thank you very much. And but then otherwise, I would go through those topics a little bit more. So we talk about PDR and DME. And then in protocol S, then in fact, when you look at the data carefully, that there's actually no meaningful benefit for anti-VEGF over laser over 5 years. And I will show you the data. PRP is obviously cheaper, even considering that if you're not using the more expensive anti-VEGF, they're still probably cheaper. And again, multiple groups now in the US have shown that if a patient who lost the follow-up, and if they were only using anti-VEGF, they also do quite badly compared to who started on PRP. In terms of diabetic macular edema, that they kind of move toward the direction that, in the protocol V, also, that if you start the anti-VEGF immediately, it does not really give you any advantage. So you can wait. However, that if you do laser, because in the protocol V, they're comparing three things, and then actually by doing laser, you're reducing the requirement for anti-VEGF much lower. And even if for those who actually need anti-VEGF, will need less injection. So I don't know how much that you have seen those data set, when they were there. So this is protocol S. This is the slide deck from the website. So it's not something that we dream up on. And as you can see that in protocol S is PRP versus ranibizumab with a deferred PRP requirement for the PDR study. So they're all PDR patients. It doesn't go. Okay. So first of all, that there's about 66% of the participants actually complete a 5-year study, and excluding death. But if you're including the death as well, that is only about 60% get there. And then, but you need to, it's too fast. And then, but you can see that because the protocol is slightly different, and then in the ranibizumab group over the 5 years, there's 43 visits. I can imagine that for a PR, a lot of patients, a lot of colleagues here who have diabetic patients with PDR, you see them 43 times over 5 years. So it's quite a number. But then because of the even because it's the clinical trial, so even the PRP group that it did be seen in 21 visits. So quite a lot of visits for that. And then I think that we look at the number of injection is in the ranibizumab group that they will have 19 injection, and then in the PRP group that they have 5 injection. But again, those 5 was given mainly for DME because they allowed DME on baseline to come into the study. So that was why that they were using anti-VEGF. And then again, you would expect that you lead 2 sessions of PRP over the 5 years, and then when you ranibizumab, that you don't have any PRP session. So when you're looking at that, the first 2 years data was presented initially, and there was some excitement to say that anti-VEGF seems to be better, showing a little bit of efficacy, better result. But again, most of those are driven by those who got DME in baseline. But then once you treat them, then doesn't go, yeah, and then actually then really they level out. So there's really no real benefit from that. Again, I know that some of you taking picture. Feel free to take picture if you want to, but it's on their website. So if you want to go to the website and download the slide, you can have that slide, even higher quality. And then you can see that really the difference is not there. And then, one of the big push for some time is that, well, when you do laser, you lose your visual field. And then so when you're looking at the data, and I say, yeah, there's a difference, although that even on the ranibizumab group also they lose some visual field. But bear in mind that when you're looking at their data, it's actually the 30-2 and 60-4. So 60-4 is really quite far out. And so you need to think about that, well, does it really matter when your 60-4 is affected? So I was looking at it, well, if you're just looking at the 30-2, then again, there was virtually no real benefit again. So again, in the US, you had a bit of discussion about that, the concept that when you got, say, visual field loss more with PRP, doesn't seem to be the case beyond 2 years. The first 2 years seem to be yes, but then after a few more years further down the road. And again, initially people don't know why, but I think increasingly that we now know that anti-VEGF do not improve the peripheral perfusion. So that is certainly one belief that the ischemia continues to grow. And in fact, in Clarity, that a different study in the UK showed that in even the anti-VEGF treated group, the retinal perfusion continues to grow, and that would explain that the protocol has potential visual field loss. So one of the really key advantage of PRP sometimes is that, well, one of the key advantage of anti-VEGF is they might be able to preserve visual field better. And again, that is called into question when the protocol S data come out, in particularly the 30-2. So again, this is the cost. Again, if you use Avastin, it might be a little bit cheaper, and to be honest, but again, still, there's a massive difference on the cost base. So I want to also show one slide that from Wills Eye Hospital was published recently. Because there was a debate when protocol S data come out in the first 2 years, seemed to be better, less visual field loss, should we do it? And then in fact, some doctors do it in the US, when it's approved and it's allowed and, and so on. But then they obviously say that, well, even in the protocol S, like 30-40% of the patient did not manage to continue to follow up. And again, a lot of practice of the same real world problem. A lot of patients will lose the follow up for more than 2 years. So this is the patient actually did come back, but then they did come back more than 2 years. So what happened that they will find a bunch of patients that, who lost the follow up for a significant period of time. And then they actually then look at that, what happened to them when they come back. So it's a bit confusing slide because they're using logMAR. So when I first looked at the slide, oh, great, anti-VEGF are doing better, although I was surprised. And actually, when you look at it more carefully, they were using logMAR. And so logMAR means that the higher the number, the poorer the vision. And in fact, that on the blue line, which is the anti-VEGF line, that is the 20, is number 1 with the 2200 or 660 or the 0.1 line, for the visual acuity. And then, but for PRP, that it seems to be settled them down quite quickly. And in fact, some of the patient came back is because of visual hemorrhage. But again, you can see that the anti-VEGF group, despite that they come back and try to fix it, and is still not able to improve the vision back. And even a year and more than a year afterwards, they maintain to have poor vision. So that has been a kind of risk that, if you really want to use anti-VEGF as your sole therapy, you need to really make sure that you follow up the patient very, very carefully. So go to another study by the LCR-NET, the Protocol V study. And in Protocol V, you have to have central involved DME. So it's not like that you got DME in peripheral. And then you have to have very good visual acuity. And it's defined by 20/25 or better. So like 0.9, or 6.75 or 6.65, 6.75. And again, the headline news is, well, really, there's no difference, So you can do, you can start with aflibercept, you can start with laser, you can start with observation, So the arguments that, well, if it's no different, then why do you want to inject the eye? And then, might start with observation. So I think that was the conclusion for DLCR-NET, to a certain extent. But even the chair, Jenny Sun, was actually in a debate who say that, well, although that you can start with observation, I think at least that, you got some support that you can start with observation. But on the other hand, that, if you actually do start with laser, then you actually had a significant reduction of the requirement starting aflibercept. So in other words, that you would be reducing the patient actually needing injection, and if you start doing laser. And in fact, that they showed the recent data that not only that even for those who actually started the injection, and then they actually also need less injection for those patients that who had laser before so. Now again, this is not necessarily statistical significant, but then but again, the kind of idea is that if we can actually continue to do laser, it might be actually a better option than not doing laser. So go back to the take-home message again. PDR, DRCL next show there's no really meaningful benefit over 5 years. PRP is cheaper. Patient loss to follow-up is a big problem. So if you decided to use anti-VEGF alone, then you need to be very careful. Make sure the patient are followed up very carefully. For protocol V is also supporting that, if you got a good vision with DME, yes, you can observe, certainly probably not starting anti-VEGF. That was the kind of general recommendation. But again, if you do a laser, then you can reducing the risk of using, the risk of needing anti-VEGF and so on. And then also that reducing the number of injection required. And then obviously the question is, this is, in this study, are using conventional laser. And again, some of you will know that for many years that we already project that, one of the reasons that we don't want to do laser because laser causes scarring on the retina. And that is why that, we want to do some other option. And then my other colleagues in the panel would actually discuss those in a bit more detail. And similarly that, the Diamond study that was just published last week online, so we didn't have time to incorporate those things into the slide. It also reconfirmed that micropulse laser or subluminal laser have the same efficacy over to conventional laser. But obviously, subluminal laser have potential advantages when there was no scarring on the retina. Thank you very much. And then I think that we're going to take the discussion at the end, and it might be easier. And then I will ask Dr. Filloy to do the second talk, and then we carry on with that. Thank you very much.
Good afternoon. It's great to see you all. So, my talk revolves around central serous, which is a hot topic lately due to the shortage of verteporfin, which is more or less affecting us all. So, a quick recap. CSC is prevalent, right? If you have a moderately busy office, you see a few cases every week. It's mostly as to also a benign condition that resolves with virtually no consequences. But we know also that there is a significant part of cases that evolve towards a irreversible visual loss, sometimes even severe, if they are not treated in time to stop exposing the retina to that subretinal fluid. And now we find ourselves that the unavailability of verteporfin, which is necessary for photodynamic therapy, is causing the cases to accumulate at the PDT waiting lists. This way, we are creating some kind of a public health crisis here. So, logic question, all right, PDT is not available, we don't know when it's going to be back. Do we have anything besides that works? We wrote a small piece of evidence, a review of the current literature of this, it's freely available. So, I'm going to present it like this. I'm going to present with this new PDT technology. First of all, verteporfin is unrequired, no advisory necessary. So there is no price, because it's not cheap either, and no availability issues. Patient can retake his or her life right after the treatment. There is no sun protection required. There is no need to stay at home for a couple of days. You can do it guided with OCT or fundus autofluorescence. It's easy to perform. It's safe to perform. There are no described complications. You may retreat as much as you need. And, well, the important thing, it works. So, how are we doing so far? Are you interested in this? Well, this new PDT technology is not new, it's not PDT, it's subthreshold laser that hits all these points. Some of them cannot be discussed. I mean, verteporfin is unrequired, period. But let's center about the last one, which is the one with real matters now. Is it effective? Does it work? Well, the evidence says yes. Here we have this. This is a table prepared by Dr. J. Chaplani of the last published case series of them yielding positive results, some better, some not as much, but most of them showing good response and certainly much better than doing nothing. But perhaps what we are more interested in is, all right, subthreshold versus PDT, what is better? In the last year, we had a couple of interesting comparative studies. This is one of them, the one made by PACORES, the Pan-American Collaborative Research Study, which concluded that subthreshold laser is a viable alternative to PDT because in that study it yields similar results, both functionally and anatomically. Then we have the PLACE study. It was a well-organized study in the sense that it was a prospective study, comparative, and so on, and yielded a clearly superior result for PDT in respect to subthreshold laser. However, the PLACE study is not devoid of its own problems. First of all, the main outcome to determine the success of the treatment in this study was the speed of resolution, which is not necessarily relevant. I mean, few more weeks of extrafoveal subretinal fluid will not change your prognosis. There were no long-term significant difference in visual results, and perhaps the most important, the way subthreshold laser was delivered, was performed. It was using unpatterned technology, so spots one by one, way inefficient. It's very easy to leave blank spots, and with a very short number of spots. Right? Those of us who used to treat central serif with subthreshold laser, we usually go for about 300, 400, 500, 600, 700, even more spots for treatment. I think the average number of spots for the PLACE was under 150. It was treated, those patients were treated kind of as if it was a focal laser, just hitting a point with a few spots. But that's not the case with subthreshold laser. It doesn't work this way. Subthreshold laser, as you know, works stimulating large areas of RPE, so you need large areas treated. Otherwise, you do not get a clinically significant response. There's quite a controversy in this laser methodology. You will see, if you look for the PLACE study, you will see a lot of letters to the editors, answers to them, answers to the answers, and so on. Anyway, including the PACORES, the PLACE, and other similar studies in the last meta-analysis made last year concludes that subthreshold laser might be considered an alternative to PDT as a first-line therapy, since it yields similar results. Let me talk to you a little bit about our own experience. I'll be presenting you a prospective case series. All those patients were treated by chronic CSC with yellow laser in a confluent extense pattern, fovea sparing, sorry for the typo there, and at a power which was individually titrated. We measured the effectiveness in terms of visual acuity and subretinal fluid resolution. And we also looked for changes in the choroidal structure under the treated area, basically which were the changes, if any, in the choroidal thickness and in the choroidal layers, inner and outer layers. This is an example of the measurements. We didn't measure exactly like this. It was a little more complex. We averaged several measures from the same point, but just for you to take the idea that we measured as well as subretinal fluid, the thickness of the core of the whole choroid and also the inner and outer choroid separately. Results include 43 eyes, most of them male, with an average follow-up of 19 months, although this study is limited to 12. You can see most of the patients experience some kind of visual improvement. These changes are visually significant without no one worsening. Regarding subretinal fluid, the overwhelming majority of patients experience some kind of improvement, and most of them were comprised of those in which the subretinal fluid was totally resolved. Choroidal thickness. It decreased globally both in the inner and outer layers, but we had a more powerful, proportionally larger response in the inner layers. We obtained this by calculating this ratio. Before treatment, the ratio between the thickness of the hyalar and inner layer was 5.5, and after treatment, this ratio increased to 7.8. So both layers thinned, especially the inner ones. All right, another way of showing the global decrease in choroidal thickness. Another more relevant points regarding the results: we did not detect any adverse effect, choroidal neovascularization, laser scars, wherever, and choroidal thickness in the untreated fellow eyes remained stable, no thinning there. Show you a few cases, few examples. This patient with a fluctuating temporal scotoma, 12 weeks after treatment, that remains stable after 1 year. We treated this area with about 500 spots, which, as you cannot see, are there, and are not visible either at the autofluorescence. I like very much to use autofluorescence to check on the subthreshold laser to make sure you are not exceeding the power, and I also like to use these thickness maps in order to monitor the follow-up. Another case, this one after 2 failed attempts of PDT at 6 weeks. Subretinal fluid is about the same, but we have a complete resolution of intraretinal fluid, 6 more weeks and 6 more months. One more case, this more chronic wall disturbance of the outer segments, so the visual recovery was not as high. In a few months, we had a recurrence of subretinal fluid, which responded nicely to another dose, and so far this day remains still. So, subthreshold laser has been effective and safe in our case series. We have observed a significant reduction in choroidal thickness, especially in the inner layer. This may indicate an effect of subthreshold laser on the choroidal vasculature, which is believed to be at the core of this disease, although we still do not have yet a clear pathophysiological explanation for CSC. There's no doubt that the choroidal vasculature is at some point involved. These findings, these choroidal thinnings, prove there is an anatomical response to subthreshold laser, so yes, it does something. I mean, I still hear nowadays, well, you do not see it, so how can it do something? Well, here you see it, choroid now is thinning. Exactly as it happens with PDT, by the way. And overall, published evidence, as well as our own, supports firmly subthreshold laser as a first-line therapy for central serous. So a lack of verteporfin should not be a problem to treat properly these patients. Thank you. Any doubt, you can contact me. Make sure you check on this.
Thank you. So as I said, we'll keep the discussion at the end, and then next speaker is Dr. Fong.
Thank you very much. Good afternoon, ladies and gentlemen. Thank you very much for having us and joining us for your lunch symposium. I know you have many options today, but I think this is the only retina laser symposium in the whole of EURETINA conference. And most of us will be burnt out by the Street and Extend and the numerous new anti-VEGFs and new drugs agents. But I think retinal laser remains a very important topic that all retinal specialists should be aware of. So my task today is just in 15 minutes just to run through the basics of subthreshold laser, the principles, the basic science, and the evidence of its efficacy. It's not a new technology. It's been around for almost 20 years. But in the last 10 years, I think we've seen a big improvement in the technologies, and in particular in the protocols and the delivery systems. So the first topic to question is wavelengths. A lot of confusion arises. Many of us have been working in this field for more than 20 years. Remember, we started with argon laser, which is essentially a green 532 nanometer laser. And that's the laser machine that almost every eye clinic or eye hospital has around the world. So as you can see here, the 532 wavelength is a very effective wavelength at doing photocoagulation of the retina. It burns the retinal pigment, the epithelium, very well. Very effective at doing a good PRP. But when you're doing focal macular treatments, you find that there is quite a bit of absorption by the xanthophyll pigments, which you want to avoid when treating the macular region. And then there's a 561 laser, which is somewhere in between green and yellow, and that's also available on quite a few machines. But the problem with that is there's not very good absorption by the hemomelanin and oxyhemoglobin region. So what we have now is the 577 yellow, which we feel is the best alternative because of its lack of absorption by the xanthophyll pigment. We're able to target the melanin and hemoglobin cells, and also penetrate cataracts, which is quite common if you're in your senior patients with a cataract and DME, and you're struggling to get a burn on the macular or retinal region. So there have been many studies looking at this topic. I won't run through them, all of them. But I mean, even from 20 years ago, the yellow laser was, more than 20 years ago, the yellow laser was recognized as one of the better wavelength for doing retinal laser treatments. And because we have the fiber in a compact diode technology now that can generate a pure yellow wavelength and is manufactured by almost all the major laser manufacturers. So what about subliminal laser, which is the patented technology that Quantel is using? This is basically based on very old technology whereby you break up the laser pulse into many extremely short pulses so that you reduce the amount of heat diffusion or absorption at the RPE layer. So, and I think a lot of you will be familiar with this slide. It's been shown over many years. So you have a on time where the laser is applied to the RPE, and then there's a short period of off time where the cell allows to relax and cool, and then an on again. And this is done over a very rapid time. So it's very similar to other companies. Iridex also produce a subthreshold laser. They call it micropulse, and very different trademarks, but it's the same technology essentially. And up to about 5 years ago, the micropulse terminology was used by Quantel, but they've had to change it because of disputes with Iridex. So, and the next concept all of us need to learn when we are treating retinal laser with subliminal laser technology is the term duty cycle, which is really the percentage of the amount of time the laser pulse is on in comparison to the treatment time. And what we recommend is a very low duty cycle when you're applying subthreshold laser or subliminal laser of about 5%. So the on-off setting on the laser machine allows you to adjust the duty cycle. But nowadays, the modern laser machines, so you just choose the percentage of duty cycle that you want rather than the on-off in the earlier generation of lasers, which was quite confusing. A classic photocoagulation laser scar would be 100% duty cycle, which is not what we do for macular laser for diseases like DME or CSCR. So at 5% duty cycle, you allow a low thermal diffusion because of a long off time. And how does it work? There's very good evidence that there's a biological reaction when you stimulate the RPE cells. And this has been shown whereby the lower the duty cycle, the less damage there is to the RPE cells. But there's upregulation of matrix metalloproteinases, which allows the fluid to be absorbed. So again, there's a lot of evidence to show that by stimulation of RPE cells, you are increasing the anti-angiogenic factors within the retinal area. I'm not an expert in this area, I have to admit, and a lot of these basic science slides are taken and collected over the years. But there's good evidence that sublethally heated tissue remains viable after subthreshold laser. It stimulates RPEs, triggers a stress response, and this stress response allows the overexpression of particular genes that can modulate the biological factors leading to fluid accumulation within the retina. And these are primarily anti-angiogenic and restorative. So you can't do subliminal laser for retinal tears. You don't do it for proliferative diabetic retinopathy because for those two conditions, you need a burn. You need a 100% duty cycle burn to create a scar. So what we're aiming for here is not to have a scar at all, but to tickle the RPE and stimulate the absorption of the fluid. So it's very, very effective. Alejandro has already showed the good evidence for CSC. We don't have time to cover DME, which is a whole symposium in itself. Suffice to say that there have been many, many similar studies done looking at how effective it is. I myself ran a similar trial to the Diamond almost 10 years ago with the first generation of subliminal laser at 15% duty cycle, and we found that it was equivalent to conventional laser. So titration is very important. We have also, I will touch about that later, but it's important that you adjust the power of the laser to the patient. So in Asia, our patients have more pigmentation in the RPE, so we need a lower power to create a reaction. But of course, in Europe, your Caucasian patients may have a lower pigmentation, so you need a slightly higher power to see an initial burn before you reduce the power by 50% at 5% duty cycle. So I think Alejandro has showed we have a Subthreshold Ophthalmic Laser Society created 2 years ago to discuss all these issues and questions that you may have. And I encourage you to visit our website where we have all our videos, protocols, and other discussions uploaded there. So we have the titration therapy guidelines. You can visit the Quantel booth and they have this all available as a handout. I won't go through every single detail. But suffice to say, a 577 nanometer wavelength is important. 5% duty cycle is what's recommended. Earlier studies were using 15 to 10%, and we found that was really not necessary. You need to do dense treatment, as Alejandro showed on his patient with chronic CSER. He went within the peripapillary region where there was a leak on the OCT and FA, and you treat a large area, and the burns are contiguous, 160 micron spot size, about 500 burns, about 500 spots are required. So these are the laser settings where you start with a spot size of 160 micrometer, duty cycle of 5%, 0.2 seconds of exposure. Recommend a typical macular laser lens, whatever you prefer. Titrate the power. So you pick an area outside of the macula. Choose a power 600 milliwatts, for example. If you see a light reaction, then there's a button you press on the Quantel machine. You just press it and it reduces it by 50%. So you are using 300 milliwatts at 5% duty cycle over the thickened areas. So again, we use OCT guided treatment, but for CSR, it's important to have ICG and fluorescein angiography to know where the hot spots are. And you have to treat them all, the spots have to be treated together, which is why it's very important to have a pattern. Rather than single spot, I use a square pattern, and I can enlarge or make the pattern smaller as and how many burns you want. You can customize the size of the grid according to the thickness of the area, so you don't forget where you're treating. And I think what Quantel has now, which is very helpful, is a MOSA system where you actually can record your retinal laser treatments. I encourage you to check it out. It's very interesting, and you're able to teach residents as well how to do macular laser. So can we go over the fovea? That's also a very common question we get. And I do. I mean, if the angiography shows a chronic CSR with leakage over the fovea, or if the center involving DME, yes, I do treat over the fovea at 5% duty cycle, and it's very safe, and we've had no issues with that. So you can see here, you can treat a very dense area. You can avoid the center fovea region, but again, at 5% duty cycle, you're not really sure. It's relatively easy to do and safe. You have to be patient. Similar to traditional laser, you need to wait up to 3 months. For DME, at CSCR, you can see a reaction within a month, quite fast actually. So here are some examples. I won't run through that. Alejandro has already presented his cases very well for CSR, but here are some of his cases. DME is a big issue, and I think all of us have seen rebound cases of proliferative diabetic retinopathy and DME when the patient started coming back after the COVID lockdown, sitting in a house, eating, drinking, watching Netflix all day long, and then it not only increases myopia, but also increases all other sedentary diseases. So here's a case from Alejandro. I love his photos, so I thought I'd share it. Patient with that extrafoveal DME, non-center involving at 3 months, and at 6 months after treatment, the DME is resolved with just one application of subliminal laser. So I think for foveal involved diabetic macular edema, I do combination treatment. So I start with anti-VEGF to dry out the macula as much as possible. At 3 months, if there's still residual extrafoveal edema, I do top it up with some subthreshold laser after discussion with the patient. Some patients may not want it. Some patients are quite happy to have injections, but I think most, when offered the option of a laser which is not painful, no injection, no risk, I think they'll be happy to try that as well. Here's a case from Alejandro, foveal involving edema, when at first treated with anti-VEGF, and then at 1 month topped up with some subliminal laser, and then good results. So in summary, 577 nanometer laser is the best wavelength for macular laser. We use it as first line for CSAR now, not only because of the verteporfin shortage, but I think because the evidence shows that it's as good as PDT and with verteporfin. DME as well, patients. In Asia, we have a big epidemic of diabetes. Our patients are definitely not as well controlled as in Europe. Malaysia, unfortunately, has one of the highest rates of diabetes in the Asia-Pacific region. So we have many, many patients that can't afford or don't have the time and effort to come back for regular intravitreal injections, and the laser remains an important modality. Don't use it only as a rescue, and you need to wait up to 3 months to see an effect. So before that, I'd like to welcome you to Malaysia in February for the APAO 2023 conference. Thank you.
So as mentioned, that we keep the discussion to the last one. We had Dr. Wu going to give the last talk on the topic of laser to drusen, and I think that can you run that?
Topic of laser to drusen in Mac. Hi, this is Lihteh Wu from San Jose, Costa Rica. Today I would like to revisit the topic of laser to drusen in macular degeneration. These are my disclosures. Please note that I am a speaker for Quantel Medical, one of the laser manufacturers. So we all know that drusen are extracellular deposits that lie between the basement membrane of the RPE and the inner collagenous zone of Bruch's membrane. Furthermore, drusen site is important, as illustrated in the clinical classification of age-related macular degeneration. You can see here that depending on the size of the drusen and the number of drusen, eyes can be classified as having early or intermediate AMD. In addition, depending on the size and the number of drusen present, eyes can have a quicker progression or a slower progression to advanced neovascular AMD. This was long recognized close to 50 years ago by Dr. Don Gass, where he stated that drusen were a risk factor for the development of deciform macular degeneration. He was first to propose prophylactic laser photocoagulation for eyes with high-risk drusen, and he observed that low-intensity ruby laser photocoagulation applied to individual drusen caused them to disappear. Unfortunately, these ideas were sort of lost for a couple of decades because clinicians were busy treating neovascular AMD with the laser. It was not until 1998 that these ideas were retaken in the choroidal neovascularization prevention trial. Unlike Gass's idea, they felt that it was not necessary to treat the drusen directly. So this is the pattern of treatment. You can see here the eye with drusen, and you have these 3 semicircles where different laser burns were performed. So there was no intention to treat each drusen directly. Here you can see an eye with drusen before treatment and after laser treatment, and you can definitely see disappearance of the drusen. In fact, the study showed that in those eyes treated with the laser, where they had at least a 50% drusen reduction at 1 year, those eyes experience increases in visual acuity and contrast threshold compared to eyes with less drusen reduction in control eyes. However, there were a number of eyes that also developed visually significant exudative macular neovascularization. These lesions were often occult, subfoveal, and associated with the region of treatment. So in order to try to diminish these complications, another study was designed. This was a multi-center randomized clinical trial assessing over 200 eyes. And here we had two arms, arms in the unilateral arm and eyes in bilateral arms. Patients in the unilateral arm had already lost one eye, the fellow eye, to advanced AMD. So here we have 32 eyes that were observed, 27 eyes that underwent visible spots with the 810 nanometer laser, and 16 eyes that underwent subthreshold spots. In the bilateral arms, similarly, there were eyes under observation, eyes that were treated with visible spots with the 810 nanometer laser, and eyes that were treated with subthreshold 810 nanometer burns. Here is a diagram. Again, there was no intention to treat the drusen directly. So these were 48 laser lesions in a grid pattern of 4 concentric circles. The visible burns were 200 milliseconds, and the power was increased until you obtain a mild gray burn. For the subthreshold burn, it was the same as above, but using 100 milliseconds as the time of exposure. These are the results of the trial. And you can see that the infrared 810 nanometer laser in non-exudative intermediate AMD reduced the drusen levels. And in those eyes, it improved the visual acuity. There were less complications with the subthreshold mode. The macular neovascularization was similar in treated and observed eyes. However, 6 eyes developed choroidal neovascularization in eyes with visible burns. The rate of macular neovascularization in treated eyes consistently exceeded those in observed eyes, up to 16% compared to 1.4%. In addition, these treated eyes show a higher rate of visual acuity loss at 3 and 6 months. So it was deemed that prophylactic subthreshold 810 nanometer diode laser treatment to an eye with multiple large drusen whose fellow eye had already had a neovascular event should not be performed because of the possibility of a high rate of choroidal neovascularization. Another study was designed where it was the patients that were included were patients with bilateral large drusen. So for over 1,000 patients with greater than 10 large drusen and a visual acuity better than 20/40. Again, there was no intention to treat the drusen directly. So we have this pattern that you can see depicted here, 60 barely visible burns using mostly green laser, but any laser could be used. At 5 years, there was no difference in visual acuity loss, choroidal neovascularization, contrast sensitivity, and the critical print size. So the conclusion of this study was that low-intensity laser treatment did not demonstrate a clinically significant benefit for vision in eyes of people with bilateral large drusen. This Cochrane meta-analysis concluded that laser photocoagulation of drusen leads to their disappearance. However, the treatment does not result in a reduction in the risk of developing neovascular AMD, geographic atrophy, or visual loss. So we thought at that point that everything was already said and done about laser photocoagulation. However, laser technology has improved and changed over the years. And we come across the Lihteh study, where close to 300 patients with bilateral drusen and without OCT signs of atrophy were enrolled. These patients were treated using a subthreshold nanosecond laser versus sham at 6 months interval. The laser here used was a 2RT, which was a 532 nanometer Q-switch neodymium dope yttrium aluminum garnet laser, or the YAG laser, with a 3 nanosecond pulse duration. And the subthreshold laser spots of 400 microns in diameter. And these were treated 6 spots just below the superior vascular arcade and 6 spots just above the inferior vascular arcade. So they reported that progression to late AMD was not slow significantly with the subthreshold nanosecond laser compared to sham. However, a post-hoc analysis showed that there was a 4-fold reduction in progression in those eyes without coexistent subretinal drusenoid deposits, or pseudodrusen. And in fact, there was an increased progression rate, a 2-fold increase in eyes with subretinal drusenoid deposits, or pseudodrusen. So in summary, direct and indirect laser photocoagulation of drusen leads to drusen resorption and improved vision. Direct and indirect laser photocoagulation of drusen leads to an increase in macular neovascularization. 810 nanometer subthreshold laser did not improve the outcomes. But the subthreshold nanosecond laser increased progression rate in eyes with subretinal drusenoid deposits, or pseudodrusen, but decreased the progression rate in eyes without subretinal drusenoid deposits. Currently, we do not recommend.
So I'll probably finish that sentence, as you probably can see that currently we don't recommend subthreshold laser for drusen treatment right now outside control trial. So we've got about 10 minutes for questions, and please go to the microphone if you have a question. But I start one first. That when we to Dr. Filloy, that historically that we thought about that PPD reducing the choroidal perfusion, and actually that there are some earlier studies say focal laser do not actually change the choroidal perfusion. But do you have a opinion, why the micropole laser would actually have the same effect on the choroidal thickness?
Well, the fact that both thin the choroid, I don't think it means necessarily that they do it both the same way. I mean, we know quite well how PDT works. It basically does a focal thrombosis of the choroid. It's called being choroidal remodeling. Those thinning the choroid by restricting the vessel content. I mean, instead, probably subthreshold laser works in a most basic way, attacking more directly the physiopathology of the disease. So we know central cirrhosis is a pachychoroid disease, so there is something wrong in the choroid. It appears thick, it appears packed. So there is something wrong with the choroidal vessel, because the choroidal is 90% vessel. So, and the effect we know that subthreshold laser elicits from RP has a vascular effect. So it has a remodeling of its own, but through a different way. But it's all very hypothetical.
Any questions from the floor? So while we're waiting for another question on the floor, there was Dr. Fong, so you talk about the wavelength on CSC. So do you think that between 810 and 577, in particular, that I think Dr. Filloy also hinted on the play study using 810. So not only the wavelength is different, but also not on pattern. I mean, do you have some feeling about it?
Yeah, I agree. I think the biggest weakness of the PLACE trial was the use of the 810 wavelength, which I didn't show on my graph because we don't consider that a viable wavelength for retinal laser treatment, because of the depth of penetration, is really used more for cyclodiode laser. So 810 was a traditional, very old technology laser that has a lot of absorption by many other structures within the eye. I think we've got a question from the online. They are asking about the parameters for subthreshold laser, and I think you can refer to that on the subliminal laser or subthreshold ophthalmic laser society website. And for power, we do titration. Yeah.
There's a gentleman at the back. You answer the question for. Okay, right. So the first question, the gentleman in the front. Please go ahead.
When I treat patients with CSR with subthreshold laser, I used to do I do a fluorescein angiogram, and then I treat the leaking point with 15% duty cycle. Do you think it is necessary or not? And the other thing is, my other question is, do you do ICG when you treat CSR patients, and what's the point of doing an ICG when you do a very extensive laser?
Well, I believe you pretty much answered yourself the last question. I believe there is no point. I mean, in most cases, since you do not need a hot spot exactly to pinpoint a certain spot to burn or to coagulate in that point, you have to treat a large area. Usually the information provided by OCT or fundus autofluorescence is more than enough. You're going to treat a very large area, which will certainly include the hot spot, which I think it wouldn't change much, not even if it wasn't included, because the success of the treatment consists precisely in treating the healthy RPE. So it produces beneficial molecules that will help restoring the sick retina. So yes, I don't think there is much point, or at least I very rarely nowadays do any angiogram exams on the CSE patients. And the first question, I don't think there's necessary for this same reason. I think there is no need to use two different systems, two different kinds of duty cycle, or to treat in a especially robust way the hot spot zone. I think by treating at a 15% in that area, you are kind of combining the subthreshold treatment with a very mild focal laser. So which will work almost for certainly with a higher risk of causing a scar or perhaps a rupture in Bruch's membrane and neovascularization.
So I think that, some years ago, people were using 15%, and my first paper was on 15%. And then by subsequenting all the work, I'm moving to 10% and then 5%, and we turn out that 5% seem to work as good and have a lower rate of complication. It's also supported by animal work that also suggesting 5% will get all you need. So at least that it will be safer. So obviously 15% actually work as well. But again, always the safer is a good thing. Gentleman, question there?
I work on a 577 yellow laser. And I had two questions. My first one was just answered, so thank you. And for the second one, in a CSCR patient that is acute, how do we know that it's the effect of the laser or the fluid results by itself in a patient that is naive?
Yeah, so I can answer that question because actually one of my patients, I have a discussion with them on that. So some years ago, that we want to say, wait for a few months, but again, the problem is that when you wait for a few months, that some of them become chronic. And then I had a British Airways pilot. They said that, I have this problem. I can't go back to work. And then and I said the same discussion. There's a few years ago that, I think the risk is almost zero because we haven't seen, if you do it properly, the risk is very low. But then we don't know whether you get better on his own or you get it better from the laser. And he said, I don't really care because it got better and then I can go back to work. So I think in a controlled trial situation, then yes, but again, increasingly, it's very difficult to justify to do a controlled trial anymore when we have so many trials. Now, whether that we can actually be able to do a 400-500 patient trial again, it's very difficult to justify a kind of not treating, patient. And then I was amazed that some other colleagues in the PTT trial are still trying to do with observation. So ethically now, I think it's hard that your question probably never get answered. But then end of the day, if the patient get better, does it really matter? So I think that was a kind of how we think about it. But I don't want to ask the panel, whether do you still wait? Because I tend not to wait anymore, because I think that initially it was 3 months, and then be a month, and then you'll be, if you walk through the door, enough for you to walk through the door might be actually already a few weeks, who knows, So again, depends on the patient. You can talk to the patient, but I don't know whether other panel.
Yeah, I think I would treat them quite early, acute CSCR. They are significantly affected. The fluid can be quite a lot. With regards to the first question about angiography, I do fluorescein and ICG because ICG is important to exclude polyps. We do get a lot of PCV in Asia that can masquerade as CSR. So once I've excluded the polyps, I know what I'm treating with.
Have you tried?
Just let the gentleman finish. Have you got your question? Yeah, okay.
Yeah. And then FFA in acute CSR with the leaking spots. So we know where we're treating and we can target the laser appropriately.
Do you want to get back? I think the lady got a question as well, but let you get back first on the ICG question.
Have you tried micropulse in polyps?
There's a lot of work
because
being done.
I have tried that.
Yeah, there's some papers in India and China. We've been had some discussions separately on that.
Yeah, I think that I think it's a good point that for European practice, BCV is not such a big problem. So, but I think the point might be different in Asia. And again, I think in the EURETINA 6-7 years ago, I was suggesting that would some of the Asian colleagues to try micropulse on polyps. I'd done a couple of cases, then it worked, but again, I hardly see any PCV, so it's very difficult to justify for us in the West to do the study. The lady over there.
Hello, I have a practical question. We used to do subliminal laser, yellow laser ago, with the fixed energy scheme of approximately 250 milliwatts. And now we acquired the EasyRed platform. We're just brand new to it. And the company recommends using the threshold strategy. Out of practical points, I was a bit afraid of applying the subliminal laser with energies that were in our Caucasian population much higher than I was used to, which was 250, right? Because I got to 350, 400 milliwatts. What is the usual energy in Caucasian population in your experience?
I would say that it's difficult because I think that one of the most common ineffective of the laser is underpower. And I know that some other company would just say they're using the same power, and I think some of the recommendations are using an 810 laser, and because they can't actually adjust the power. And then when you go to 577, you have an opportunity to adjust the power. And then again, when I was in London, we had a much more mixed population. So we do feel like what Dr. Fong mentioned earlier, that in African Caribbeans or in Chinese, you can use a lower power. When I moved to Oxford, then 97% Caucasian, and then so again, I still test power, and then but again, it gradually that you say, well, you're almost always between 400 and 500 for that machine, in the Oxford population, which most of them have no cataract. So again, it does depend. So if your population have cataract as well, and so on, and then testing is good. And I think that you already mentioned earlier, it's good to, when you're learning to do the laser, is to order your result. And the way to think about it is that, if you get autofluorescent imaging, 3 to 6 months later, you see the spot, you might not see the spot clinically, but you might see it in either a detailed OCT or autofluorescent. You have slightly too much power. So you can then see that, lower it down a bit. I think that Sandra and myself had discussed some time ago that, I like to cut to 50% because before the machine helped me to do it, 50% easier. So I do the really just barely seeing something. So we actually wait for a couple of seconds. Before that, I would say, yeah, I saw something, and then that would be the 50%. I think you cut it down to 1/3. and because that again, it's just a methodology to get you comfortable. And I rather not to give you the particular power because every machine is also slightly different. I think the laser manufacturer might disagree on that. But again, the delivering system and the whole optic fiber. So that's why they're more comfortable to test. But you need to define the subthreshold part, which is actually the just threshold part. And then how you actually say, well, you want to be a little bit brighter, but you might want to divide it to 1/3. I don't know what you comment on that. I think we had discussing like 5 years ago, right?
Yeah, that's right. That's one of the first things we discussed. I mean, minimally visible burn is quite of an subjective term. I mean, magnification, illumination, and your own sensitivity all play a role. I recommend you that with anything else, you start easy, you start with conservative power, and you can climb up from there as long as you don't detect anything. There is a piece of data you can use. If you have the EasyRed platform, you'll see when you're ready to treat, there's at the bottom of all the data, there's one called Fluence.
Yes.
That the machine calculates automatically, taking into account duty cycle, spot size, and power. Right? It's given you in joules per square centimeter. Mm-hmm. Well, I always like to give it a quick glance after treatment to be safe. Anything under 18, you're going to be safe with virtually 100% of the population.
Okay, because I'm really worried about under-treating my patients on one side, because with 250, I was quite confident if I went through maybe 2 times, maybe even 3 times, and now if I use threshold strategy, can I go over the spots that I already applied once more? Because the patients tend to move always.
That's no problem, treating the same area. And what spot size did you use to work with when you
160.
160, all right.
No, I think, as I say that, it's actually better to build do some audit for your result. I think that 250, might be under treating, but again, obviously, there was always an argument that some other company recommending same setting for everyone, but then do more time. So yes, you can do that but you're under treating. But again, you want to get the optimal result, but you might need to learn a little bit. So again, it's always a balance of things. That what is the long run? So if you only practice for 1 year, then you might just want to do the standard thing. But if you want to practice for 20 years, then you might want to sort out your technique, and then you have many years of benefit afterwards.
I have another question, if I may.
Sure.
Regarding a patient that has a non-central evolving diabetic macular edema, and the thickness of the retina where I would want to treat it is over 400 microns, say. How could you comment on using the subliminal laser combined with the focal or grid?
Sorry, sublabel.
The focal or grid, the classical laser. Would you combine that? Would you not do that?
I stopped
in
doing
thicker retinas.
Yeah, I stopped doing classical, so-called conventional laser. I would say ancient scar coring laser for macular disease, because there's no need for it. So why do you want to do that?
Maybe in very thick retinas.
Yeah,
the response is a bit less.
Well, if it's extra full field, then it doesn't really matter. But I think even in full field lesion, you do want to get a faster resolution. That I think Dr. Fong and myself and like many other would start with anti-VEGF. And then again, even to be fair, that but then even in the protocol V I mentioned earlier, that if you have a good vision, you have to be time to wait, and you can still wait even. So I think that is a kind of like but obviously if you've got a thicker retina, you're less likely to have good vision. You're more likely to be treated. So again, I actually quite like to treat with anti-VEGF and actually laser and then anti-VEGF on the same day. I think that can tend to treat the anti-VEGF first and then laser a few months later. I don't think that was right or wrong on either side. I don't think we never know, because we're never going to do a control trial. When do you do the laser? So, but anti-VEGF do drive to get the improvement. But if it's extra full field, it's debatable that you need anti-VEGF that urgently, because you can almost wait until that becomes full field, and then as you get the protocol V, even then, unless the vision drop, So So I've got a gentleman standing behind you. Let him ask the last question, and then we'll finish the session.
Okay, so a quick one. Maybe it's a little bit overlapping, but how many times can you go with the subthreshold grid over an area of edema in order to be sure that it might be effective? So can it be 2 times, 3 times in the same session, I mean? And the second question would be if there are any other parameters or factors that are not related to laser that we could adjust before treating the patient in order to make it more effective. For example, combining treatment with eplerenone in CSCR or glycemia control before diabetic macular edema treatment.
Okay, that's not a quick one, but let me just answer as quickly as I can. So obviously improving diabetic control always good, but there's very little evidence will change the next few months. So yes, you still want to improve diabetic control. And in terms of spironolactone and so on, multiple studies show it does no effective, so it's more placebo. But again, some people disagree. So there might be for some very specific patient, there might be some benefit for CST. And on the same setting, I think that's what I understood, that how many times you need to do that. So I think it's the other way around. So like in some of our earlier work, we actually deliberately overtreat an area, but outside area, which is not edema area, 3 times deliberately, just to see what happened. And there was no scarring after 3 times, but we don't feel that comfortable to do more than 3 times. So that is actually allow us to a little bit overlapping. So in other words, overlapping the overlap area might be 2 times. So actually that we found that a little bit overlapping is better than under treatment. So the kind of the balance of benefit and risk, and the almost argument is that, that's why that you're doing a single non-pattern laser. It's quite difficult because you just not necessarily remember where you were. I mean, again, you need to really get in your head where you are. But with a pattern, it's a lot easier. Yes, the patient do move a little bit. Yes, you might have a little bit of overlapping, but the caution is toward a little bit overlapping. And then, because we have done some work that a little bit overlapping, no problem, and you can hit the same place 3 times, but try not to, So I think that was a kind of, realistic, pragmatic view. Well, I'm going to finish there, and thank you very much for coming. I'm sorry, running out a little bit out of time already. Thank you.